morning, Dr. Colombo. It's an honor to be sharing the dais with you. I would just present a simple case which we had done recently on BRS therapy. This is a 64-year-old male who presented with an acute inferior wall MI. He presented us a little late on the day 3 of the MI, but he was hemodynamically stable. And this is the lesion on the angiogram, the left system being essentially normal. So there is a sort of a early PD followed by the vessel, and he also had a proximal discrete lesion, slightly what we thought was around 30 millimeters, and he also had this lesion in this PLB branch, or after the early PDA branch, he had a lesion. So these are the two lesions that we thought we should address in this patient. So there was not much of a calcium visible from the angio pictures. So we decided to go in for, it looked like a fibrotic lesion. We decided to go in for MeRes in this patient. So this is the first step we did. We started pre-dilatation of the lesion with the 2 into 12 millimeter balloon. Once that was pre-dilated, the 2 into 12 millimeter balloon, we also pre-dilated the distal lesion. We did not decide what to do with that lesion because it's only a 2.5 millimeter vessel. So we thought we will take a call after the proximal lesion has been fixed. So once both the lesions have been dilated and the lesions were crossed and dilated, and this is the second dilatation we did with the 2.5 balloon this time because we were not very happy with the OCT catheter. Was hesitating to go through after the 2 millimeter dilatation. So once we did a dilatation with the 2.5 millimeter balloon, we could get the OCT catheter through, and this was the lesion after the dilatation. This is the pre-OCTs. All these OCT runs have been done with saline and not with contrast. It's a slightly big RCA, so we had a little bit of problem in clearance, but the material, whatever we wanted to see, we could see, although this is not the best pictures that we got so far. So this is the RCA, proximal, predominantly fibrotic lesion. Very little bit of calcium here and there, but there is calcium. And it was quite a large vessel to with. So if you see, look at the lesion, if you look at the vessel profile, you can see that there are 2 areas of extremely narrow profile, and rest of the area is quite roomy. So this is the lesion. It's distally it is 2.61, the maximum diameter of 2.82. Then you have a 2.14 and 2.33, about 75% of the way through. Then it comes to 2.24. Then it comes to 2.45 just before the tightest part of the lesion, which is about 1.05. And approximately the second part of the lesion is about 1.76. So the tightest lesion is 0.097 milligrams squared, and that's about the mid part of the lesion. So the point I'm trying to make out to say is that we could get all the data, we could get all the information, we could get the amount of distribution of fibrous plaque, and some amount of the disruption has already been done by the 2.5 millimeter balloon. This was followed by, this is the pre-run distal RCA. Distal RCA is a very roomy vessel. We decided that we will not go that distally and stick to the proximal part of the lesion. About 30 millimeters is the length of the stent that we planned from this OCT run. So then we went ahead with the 4 millimeter. We decided to go in for a 4 into 29 millimeter MeRes. We first went ahead with the 4 into 15 lineage balloon, pre-dilated it at nominal, slightly more than normal atmosphere. Then during the pre-dilatation, we managed to slightly dissect the vessel, quite significant dissection. So we did not take any other shots, but we went straight in with the BRS. You can see that the vessel has been dissected quite well. There is quite a bit dissection post the 4 millimeter balloon dilatation. The MERS was deployed. As Dr. Hasra had said, we put on the timer, and slowly the balloon gets inflated. It takes about 5 seconds before we reach the 4 atmosphere mark. Once we reach the 4 atmosphere mark, it's held there for another 4 seconds. After which we slowly increase the to the nominal pressures and maintain at the nominal pressures. So this is the deployment of the BRS. And once the BRS has been deployed, we waited for the total time of almost 40 seconds we held on. And after that, we went ahead and took a shot. It showed a reasonably well approached stent. And then we went in with after the second shot, this is to see actually the distal vessel also. Then we went into the 4.5 into 15 lineage balloon and did a post dilatation with the distal marker of the balloon and the distal marker of the stent slightly overlapping. So while doing so, we see that the little bit of the balloon does go into the territory beyond the stent, but that's only the tapering part of the balloon. So once this dilatation was done, we pulled it back and did a dilatation in the proximal segment. And once we did the dilatation in the proximal segment, we got good flows and we stopped at that as far as both the dilatations done with 4.5 15 lineage balloon at nominal atmospheres. So then the question of the distal lesion came. If we put in a drug-eluting stent there, then we lose the flavor of the having put the drug-eluting BRS in the proximal segment. So we decided to go in with a 2.520 sirolimus-eluting drug-eluting balloon. It is called Magic Touch. So Magic Touch was deployed distally so almost the trifurcation area. The whole area was covered with the 2.5 into 20 balloon, and after that it was inflated again, held for 30 seconds and then again 30 seconds. So once the balloon was deployed, we took shots. We found that area is also covered. It's come out beautifully. There is no pinching of the side branch, and the proximal flow is also good. This is the shot, and this is the final shot, which shows that the proximal and the distal flow is reasonably good. That was followed up with I give 2B3A in most of the high pressure lesions that we deployed. 2B3A bolus was given to this patient, and this is the final shot, and this is the final OCT run. So this is a post pull back with now the problem with saline in this case is that when you have a very large vessel, it is difficult to get an external clearance. So I decided that if I don't get very good clearance and if I can't see what I want to see, I'll take a contrast shot. So, but luckily we got most of the information. You can see that the stent has been approached very well. The areas and diameters are very good, and there is no stent prolapse. There is no prolapse. There is no areas of malapposition, and most of the places have been approached very well. So this is a cross-sectional pullback just to show you how well deployed the stent is, and there is no tissue prolapse. The proximal and the distal edges have no dissection or hematoma. This is a 3D reconstruction. This is a fly-through. This is a fly-through which looks totally eerie because there is no stent strut seen, but it is actually, this is like a golden tube. You can see there is no BRS also visible, unfortunately. Only the tissue and the vessel wall can be seen, and this is a fly-through of the same BRS post-stenting. This is the final areas we got. So from proximal to distal, we got in the distal most area is 9.6 millimeters squared. Then we come to 10.06, then come to 10.93, then we come to 11.24, and finally the proximal RCA we got an area of 11.61 meters squared with a maximum diameter of 4.47 millimeters. Thank you.